Well, it's very nice to be here. Today's talk, we're going to talk about hip and knee replacements, at least in the Q&A. And I have a PowerPoint slide talking specifically on direct anterior approach to total hip. So this is Ask the Expert. So my disclosures, really, I have no financial obligations to any company. I'm going to go through that with you. The outline for the talk is really all direct anterior approach to total hip, and then, like we discussed, open questions at the end for hip and knee replacement. Disclosures, no financial or affiliations to disclose, and it should be recognized that almost all my first-time hips are done through a direct anterior approach, so I'm a little bit biased towards this approach. Start off with some true and false questions. Direct anterior total hip replacement has no pain after surgery. Direct anterior total hip is faster in terms of recovery compared to a posterior total hip. Direct anterior approach has the lowest reported dislocation rate for all total hip replacements. Direct anterior approach is the safest way to do total hip. All surgeons should be using a direct anterior approach. So you may have answers to these questions, but we'll cover them at the end. So in terms of approach for total hip arthroplasty, there's many ways to do a total hip. The front approach, which is the anterior approach, you can see is towards the front of the body. The lateral approach is directly on the side of the hip. And the posterior approach, which is actually the most common way to do a total hip replacement, is done through a back incision towards the buttock area. If you look at all surgeons across the country, it's only about 10% that are doing a total hip through the front as their primary surgery. 20% are using a lateral-based incision, and most of the surgeons, 70%, are using a posterior or back buttock area incision. So if you look at people, or surgeons in general, across the country that are using direct anterior as their primary approach, many of them promote them as muscle sparing, quicker recovery, less pain, shorter hospital stay, and lower dislocation rate. And this is looking at surgeons, following them on their websites to see how they advertise total hips. Little mention on these websites is for nerve injury that can happen with this approach, fracture risk, and wound complications that are inherent to the front approach versus other approaches. This is just a diagram showing you a patient laying on their back on the left side, and then a patient laying on their side in the right image. And the right image is a posterior approach, and the left image is the direct anterior approach. You can see when you're doing a total hip through the front, the muscles are moved aside to do the work within the hip socket. And then for a posterior-based approach, there's certain muscles that need to be taken down in order to dislocate the hip and do the work inside the socket. Most people that do a posterior-based approach are repairing these structures at the end of the procedure, but you have to take them down and repair them at the end of the procedure nonetheless. Also, there's many different types of tables to do a total hip replacement. The table on the top of the screen on the left is the way I do a total hip. Patients laying on their back in a neutral position. The image on the right is how most people would do a posterior-based approach to total hip arthroplasty. And then in the bottom left is a specialized table that is quite expensive to do total hip anterior-based approach for people that have difficulty with exposure. Now the reason why I use the table on the top of the screen on the left is it gives me a lot of freedom to compare leg lengths. If you notice, the patient is perfectly positioned, both legs are in front in the operative field, and you can measure leg lengths after the surgery, make sure the patient is perfectly even in terms of the leg length right after the procedure is performed. In addition, because the legs are free and not tied into a contraption such as the table on the bottom left or positioned in a side position as in the posterior approach on the right, you can do range of motion testing that's really important for after surgery. That's the power of this approach on a regular operative table, is that you can assess stability of the hip during surgery to know whether or not the patient would even have a chance of dislocating post-operatively. So what are the big benefits that people talk about for the direct anterior approach. One, quicker recovery. Most people talk about the early recovery being faster with the anterior approach versus a posterior approach. The direct anterior approach also has the lowest dislocation rate, and it's been reported in the literature. So let's run through these benefits. So there was a systematic review published recently on 42 publications that used the direct anterior approach, and they showed improved outcomes in the first 6 weeks following surgery. There is a significant learning curve, we'll talk about it in a little bit, and there was no difference in patient function more than 6 weeks postoperatively, whether you did the total hip replacement through the back, side, or front-based incision. The direct anterior approach also has the lowest dislocation rate. This is a large series from the Anderson Clinic of almost 9,000 total hip arthroplasties. 5,000 of these were done through an anterior approach, 4,000 were done through a posterior-based approach, and of the posterior-based total hip arthroplasties, 3% of these hips had a dislocation event after surgery. And a dislocation event for a total hip replacement is a big deal. That usually means at least, at the bare minimum, going to the emergency room and having someone relocate the hip under sedation. So that's a big impact to patients. At the worst, it means more surgery to create a stable hip after the primary hip replacement. Of the patients that had a front-based incision, it was only 0.5% that had a dislocation event. 0.2% needed additional surgery for dislocation for the anterior versus 1% that needed additional surgery. So there's a big impact towards patients, and one of the major reasons why I use an anterior-based incision. So in addition to this, there are restrictions that surgeons place on patients. I don't know if the audience or members of the audience have ever had a friend or family member undergo a hip replacement and they've been told not to do certain maneuvers. These are called hip precautions. And hip precautions are an attempt to prevent patients from doing extreme range of motion and potentially dislocating their hip. So 44% of surgeons across the United States are not using any form of hip precautions. And the people, or the surgeons that are not using hip precautions are usually anterior-based surgeons. I enforce no hip precautions on my patients. I really just tell them if it hurts, back off, and they should get back to normal activities in their daily life. So then I just wanted to highlight one study that showed a big discrepancy in the dislocation rate. They had patients that were selected for anterior-based incision if they were high risk for dislocation, and lower risk patients were selected for posterior approach. So this is the bad actors are selected for anterior approach, or the high risk patients are selected for an anterior approach, and the lower risk patients are actually selected for a higher risk of dislocation posterior approach. And in this study, they found that the dislocation rate was 1% for the hips that had the posterior approach, and these are the supposed low risk patients. Of the anterior hips, the patients that were participating in yoga or high activities that required excessive range of motion, 0 of those hips dislocated despite being higher risk. What are the risks of doing a direct anterior approach for total hip arthroplasty? It's obviously complications. Complications are a big deal for these patients, and I'm going to highlight a few of them for direct anterior approach. So there's in the systematic review of looking at direct anterior total hip arthroplasty studies, they found that there's a 3% risk of nerve injury during surgery. And this is not skin nerve, this is actual motor and sensory nerve injury. There's also a 2% risk of intraoperative fracture during surgery. And this is a picture kind of explaining why operative fracture can be a problem. This is a small incision in the front of the hip, and you're trying to aim a trajectory of a stem down into the thigh bone to get rigid fixation and a stable implant. The trajectory of the femur, if you're not careful, you could be way off in terms of getting it securely fit. So this is a picture of somebody who was doing a direct anterior-based surgery and had a perforation of the femoral canal there. This is another image showing another type of perforation. This is a perforation that went out the back of the thigh bone. And the image on the right-hand side is what they had to do to fix this fracture, and that's a revision-style implant that was able to get secure fixation. But obviously, that's additional surgery for the patient. So the nerve injury is a big deal. So 1% of patients overall can have quadriceps weakness following an anterior-based approach. Most of these nerve injuries do recover within 1 year of surgery. What should be noted is smaller skin nerve injury varies in its report in the literature from 0 to 83%. Most patients, this is just numbness on the side of the thigh. And this is a picture of the nerves that exit the front of the hip and can be involved in direct anterior hip arthroplasty. So if you can see on the image on the right, this is the lateral femoral cutaneous nerve, and really it does innervation to the side of the thigh. So almost all of the patients have some amount of numbness on the side of their thigh, just on the outside of this incision. While that's not a huge issue for a lot of patients, it should be mentioned before surgery. And I tell my ladies who have hip replacements that you may not realize that you're numb on the side of the hip, so pressing up against something that's hot could burn you, or if you're shaving that side of the leg, you could end up with a cut because you didn't feel it. So what can reduce complications if this is, can be a problem with total hip arthroplasty through an anterior-based incision? They've done a couple reviews on this, and surgeon experience really matters. So this was a study that looked at experienced surgeons versus inexperienced surgeons, and then how many hip replacements did it take before they had fewer complications following an anterior-based total hip arthroplasty. So overall, experienced surgeons had a lower rate of complications, and that's that dotted line that you see at the 0.3%. And then the surgical volume, you can see as the junior surgeons got more than 10 to 15 cases performed, their complication rate went way down in terms of absolute number for patients. So what that tells us is that if you're going to have a surgeon do an anterior-based approach, they should have extensive training in it, one. And if you're a patient seeking a total hip arthroplasty through an anterior-based approach for the lower dislocation rate or quicker recovery, you should find a surgeon who's very experienced in this, at least performing more than 10 to 15 total hips to the front per year. So back to our questions to summarize. A direct anterior total hip replacement has no pain after surgery. Obviously, this is false. It's surgery. Early recovery is faster for the anterior-based approach compared to the posterior-based approach, but we know after 6 weeks, posterior, anterior, or lateral, most patients are doing pretty well after total hip arthroplasty. Direct anterior total hip has a faster recovery compared to posterior. That's true. We just mentioned that. 2 and 6 weeks after surgery, they're doing a little bit better in terms of their recovery, less limp, less pain than posterior-based approach. But after 6 weeks, those really equivalent. Direct anterior approach has the lowest reported dislocation rate. This is very true, and it's 5 times lower dislocation rate compared to a posterior-based approach. Direct anterior approach is the safest way to do a total hip arthroplasty. That's false. We talked about this with the experienced surgeons having lower complication rates, but volume really matters. So experience and doing a lot of total hip arthroplasties through a front-based incision matters to patients in terms of their complication rate. All surgeons should be doing a direct anterior approach. This is obviously false. There's a learning curve. Experience matters. If you're going to have surgery with a direct anterior approach, that surgeon should be experienced in that way to perform a total hip arthroplasty. So now we'll open it up to questions from the audience. That's a very good question, and age is really a surrogate for health, but it doesn't mean that a person in their 80s necessarily has worse health than a patient in their 60s. So health really matters, and general health is really cardiac issues, diabetes, rheumatoid medications, ever having blood clots, blood thinners. All these impact the outcome of surgery, and really taking a general look at the patient in terms of their overall health, coordinating with primary care or cardiology is important to determine whether a patient is even a surgical candidate despite, maybe aggressive or advanced stage arthritis. Surgery may not be the right answer for certain patients. So age is a surrogate, but doesn't necessarily mean everything for patients. Sure. Well, that really depends on the surgery. Most total knees for a primary total knee is full weight bearing immediately after surgery. Some people have restrictions on what patients can do after surgery. Some people don't. Matters more for total hip replacement for those precautions. We discussed that a little bit in the talk. But for total knee replacements, 99% of patients are full weight bearing immediately after surgery. And that, I should make just a note that sometimes there's cases where there's infection or complications with the bone or intraoperative fractures or things like that I've seen in complicated knee replacements. And in those types of situations, we may slow down patients a little bit, but most patients are full weight bearing. So it's a very good question. Most of the registry data says if something bad doesn't happen within the first 3 months of surgery, it's probably going to last you a lifetime. The long-term data at 10 years is about 98 to 99% of hips have not had another surgery. And then if you look longer out, 20, 30 years, those numbers drop a little bit, not significantly though. Really at 30 years after total hip replacement, it's 90+% of patients who haven't had another hip surgery. In the early 2000s, they've really done some excellent engineering on the plastics, the bearing surface within the hip joint. And those plastics were developed early 2000s, and to date, 20 years later, we haven't had a revision surgery for the plastic wearing out. Back in the 70s, 80s, 90s, that was actually the most common reason to have a revision surgery was wearing out of the plastic. And with that, we were able to use more stable implants because the plastics are even better. So that also helped in terms of lowering dislocation rate and other potential complications. So for hip replacements, I usually follow a standard protocol because bad things can happen at any time. We know early. We follow people closely to make sure none of those bad things occur early on, such as infection, dislocation, problems with the implant, fracture around an implant. All these things can happen. They're very, very low risk and low incidence of these things happening. But I follow patients at the 2-week mark, 6-week mark, follow up 3-month to 1-year mark, 2-year, 5-year, 10-year, every 5 years after that. But if any patient is having problems with their hip replacement after surgery, they'll be asked to come back to clinic and see me. Sure, it's a great question. I get this question actually a lot in clinic. And the way to think about total knee and partial knee is first analyze the patient whether or not they're even a candidate for partial knee. So partial knee replacement is really for patients who have isolated arthritis in one area of the knee. Now, a lot of people don't think of the knee joint as having 3 joints in it, but that's true. There's the inside of the knee, closest to the other knee. That's the inside of the knee. The outside of the knee, which is a separate area of the knee, and then behind the kneecap. These are 3 separate joints within the knee, and both have different rates of wear within the joint. So for most common people who get arthritis in their knee, it starts off with wear on the inside of the knee, the instep, which is called the medial joint. So if there's isolated arthritis in one specific area of the knee, then they may be a candidate for partial knee replacement. The idea of partial knee replacement is just replacing the one area that has been worn out with metal and plastic. That's all a knee replacement really is metal and plastic implants. And the reason why arthritis hurts is because you wear down the cartilage, you develop increasing bone pressure, and bone pressure hurts. You develop so much bone pressure that you bruise the bone within the knee, and then it's really tough to put weight on the knee for a period of time. So when you do a replacement, whether it's partial or total, you're resurfacing those areas of the knee and preventing that bone pressure pain. For partial knee, it's one specific area of the knee. So you can imagine the advantages. It's less inflammation, quicker recovery, better range of motion because the knee moves more normally. Total knee replacement is replacing both the outside inside of the joint with a resurfacing tray of the tibial, the shin bone side, as well as a cap for the femur, and replacing behind the kneecap with a plastic button. The same high-grade medical plastic that we mentioned in the hip replacements, but really knee replacement isn't replacing the entire joint, it's resurfacing the entire joint. And a partial knee will resurface part of the joint. Total knee resurfaces the entire joint, all three areas of the knee. So for people who get a total knee replacement, I usually describe the recovery as such. It's 3 months of hard work. You work really hard to get your range of motion after surgery. And after 3 months, you have a good, not perfect knee. For most patients, that's a huge improvement in their life because before surgery, they were miserable. If they had to rate their knee out of 10, they may be rated a 3 or a 4, and they can't get from A to B without having significant pain and limitations in their life. So a knee replacement improves their pain. Most total knee patients can stand for long periods of time, walk a long distance, and they don't hurt. If they're up on it all day, usually aches at night, and they put a little ice on it, or they use an anti-inflammatory. It doesn't move like a normal knee, or catches a little bit, clicks a little bit, usually is not painful. But that's what a knee replacement is. So if I was going to rate a knee replacement out of 10, a total knee replacement, I'd rate it an 8 or a 9 out of 10. Because it's not perfect. But for most patients, it's a huge improvement in their life. That's completely different than partial knee replacement. Partial knee replacement is 6 to 8 weeks of hard work. So about half the recovery. Patients have better range of motion, better function. Incision is obviously smaller for a partial because you're just focusing on one area of the knee. And people like that knee because it moves like a normal knee, feels like more like a normal knee. They have a forgotten knee score, which means that they ask patients, did they forget about their surgery at any point in the recovery? And for partial knee, most patients forget they had surgery. For total knee replacement, it's far fewer that forget they had surgery from their total knee. So they always know they had surgery, but it's a huge improvement in their life nonetheless. So whenever you're considering patients for partial, total knee, or patients thinking about partial versus total knee, I usually have them answer a couple questions. One, am I a candidate? So if you know you're a candidate for partial knee, then you can have a discussion about partial versus total. If you want a high-functioning knee that feels normal, you may want to go with a partial knee. The disadvantage to a partial knee is it may not last as long as a total knee because there's other areas of the knee that haven't been replaced, and the more durable option, meaning things that are going to last longer, is a total knee replacement, because we know at 10 years after surgery, it's about 10% of partial knees that have been revised, mostly for developing arthritis in other areas of the knee. For total knee replacement, it's far fewer. It's about 5% at 10 years. 20-year data, it's about double those numbers, so about 10% for total knee, maybe 20% for partial knee. We don't really have good 30-year data on partial knee, but I would imagine that that consistent trend stays the same at 30 years. So if you're thinking about the most durable surgery for knee arthritis, that's a total knee. Some people say, never want another surgery in my life. I don't care if it feels normal. I just need something that relieves pain. That's a total knee candidate. And then patients that want a really high-functioning knee, that don't care if they have another surgery in their life, they're willing to accept that little bit higher risk of needing another surgery, that's a partial knee candidate. So I like hot tubs and jacuzzis too, so maybe it's not the best idea while the wound's healing, but once an incision is healed from a hip or knee replacement, it's fine to get into any body of water, whether that's ocean, hot tub, pool, any type of body of water. But obviously, while the wound's healing, submerging under the water is probably the wrong answer and can increase the risk for infection. So a healed wound is completely healed, no scabbing, no problems with the incision before you do those types of activities. So we get this question a lot, and I kind of gave you the story of knee arthritis and knee replacements. So total knee replacement may be the only option for certain patients with advanced arthritis in multiple compartments of the knee. Now I told you it's 3 months of hard work, and you get a good, not perfect knee. Some people have bad arthritis in their knee, and they're doing okay. They're getting by, they're being able to accomplish most of their daily activities, but they just need something to help them. And really, the non-operative management for arthritis anywhere in the body, and applies to knees, is pills, Advil, Aleve, Tylenol, as long as you don't have any medical contraindications to taking those medications. Physical therapy, which can work on strengthening and stability of the knee. Injections, which are really two flavors, One injection is cortisone, which is an anti-inflammatory, calms down inflammation from arthritis. Viscosupplementation injection, which is really a lubricant for the knee. And using a cane or walker when it really hurts. Other than weight loss and sometimes a neoprene sleeve, that's all we have for knee arthritis. And these aren't great options. You know, most of them are over the counter and people pursue them. But the alternative isn't a perfect option either, which is knee replacement surgery. It's a good question, and really we got to understand that that's a big, big deal. Because this patient specifically asked about knee replacements, and I told you it's a 3-month tough recovery from a knee replacement. So doing both at the same time, that's even tougher. We do recommend it for certain patients. The only patients I really recommend that for are patients that are really, really young and very fit. So those patients that have bad arthritis in both knees and are miserable with both knees and they're young, active, and healthy can have it at the same time. And that's one recovery. The benefit is obvious that it's one surgery, less time off from doing the things that you want to do. What are the risks? The risks are morbidity, mortality. So there's a higher incidence of patients dying with bilateral total knee arthroplasty. It's not a huge amount of patients, but it's much higher than doing one surgery and either 3, 6, 9 months later doing another knee replacement when the first knee replacement is fully recovered. There's also other complications such as pneumonia, infection risk that have been variably reported in the literature associated higher with bilateral total knee arthroplasty. So for young healthy patients it is an option, but really should be entertained cautiously. So I don't have any restrictions on my hips after surgery. I already talked a little bit about that. So I tell patients, get back to normal activities, and if it hurts, back off. So I let patients do whatever they want. If lifting 10 pounds is causing pain, they should be backing off, especially in the early postoperative period. After about 3 months following a hip replacement, there's probably nothing that you could do to it short of falling down a flight of stairs or being struck by a car that you could do to the hip replacement. So whatever patients were doing before surgery or trying to do before surgery, I let them get back to without restrictions. So I talked a little bit about nerve damage from the anterior-based incision, and the overall rates in the literature were somewhere between 1% and 2%, and that's femoral nerve because that's the nerve in the front of the hip. Posterior hips can have a sciatic nerve injury, and that's a different type of injury. People that have injury of the nerve in the front of the hip may lead to quadriceps, thigh muscle weakness, which is tough because it's an important muscle in walking and keeping strength in the leg when you're walking on that leg. The other injury, the sciatic nerve palsy with a posterior-based approach, is really dorsiflexion of the foot. A lot of patients that have that type of injury have a real tough time lifting their foot off the ground, and that's the motor function of the sciatic nerve past the knee. Patients, that's called a foot drop, and a lot of patients, if they do get that, which is about 1% risk, or it's variably reported, so it's between 0.1 and 1% risk. And you know, every study's got a different number on the topic, but it's a big deal because patients, when they walk around, may need a brace in order to keep their foot up, and so that they're not tripping on it when they walk. But it is a complication of posterior hip replacement.